I'm Tim Wilt. I'm the session chair. It's really an honor and a pleasure to be able to moderate the first set of keynote speakers. We've got three outstanding speakers. What we plan to do is have each of them provide an outstanding talk for about 20 minutes. And then after the three of them speak, we'll have them come up front and we will invite questions and comments both from the audience live, and also they can be submitted online through the app. And Jim will be moderating that. We'll try and go back and forth with questions both from live audience and online, and including if there's questions that maybe you get a little discussion back and forth between the individuals. All right, so let's get started here. Okay. So our first speaker is Loy Albercuni, who's going to be talking about overdiagnosis and overuse of healthcare services. Loy is an assistant professor, and his main area of interest is in evidence synthesis and shared decision making. And today he's going to kind of kick things off with his discussion about overdiagnosis and overuse of healthcare services in the LMICs. So welcome, thank you.
Thanks so much, Tim. Thanks so much for having me, and I'm really grateful to be here after 3 years of no overdiagnosis conference because of the pandemic. Really grateful for that opportunity to present the work of overdiagnosis and overuse of healthcare services in low middle income country. Is it a reality? Is it a real problem in the LMIC setting or not? So first, I'll declare that I have no financial conflict of interest. Most of my funding is coming from the public funding from the Australian government and NHMRC funding, and I receive no for-profit funding. So I'll start with telling that story of my aunt from Palestine, where I'm from. I'm medical trained, I practiced for a few years. She's in her 70s, and she's diabetic and asthmatic, and she has, as most of those in that age, have knee pain. And she went to the doctor, and she have been prescribed suggested to have painkiller and some of kind of physiotherapy, exercise more to reduce that pain and improve her movement. And she did that for years, and that's the pain goes on and off until one of her neighbors suggested that there's a new orthopedic surgeon coming he's really good to treating that kind of knee osteoarthritis, knee pain. She went there, and that orthopedic surgeon suggested knee arthroscopy for her. That's very good for you. She's convinced to take that operation, surgical operation, and it's very expensive operation. And we know now that the high quality evidence suggests the benefits doesn't outweigh the harms for most of the people in that age group. But she decided to go for that operation. And it's an expensive operation and doesn't be covered in the, is not covered in, is not covered in the public health insurance. So she did the operation. She spent all her saving in the operation to do the operation. The pain improved for a few weeks, few months, but 2 years after that now, the pain started to point zero. The same pain, the same limitation in the movement, but the problem that she lost all her saving, and she can't afford even the physiotherapy that she used to afford. So it's dramatic impact in her individual healthcare system, and even in the individual health, and also if you generalize that to the healthcare system, individual impact. So we all aware of that's the issue of the overdiagnosis and overuse of healthcare services. It's just that the trade-off between the benefit and the harm is not the right. So the benefit doesn't outweigh the harms from that services or from that diagnosis or label. And there's a lot of books have been written in that. This is just a sample of these books that have been written, and lots of articles that discuss the issue. And even at Mishjam, thanks to Steve, that have been that for the overdiagnosis in the PubMed. But most of that in the high-income setting. And just to acknowledge that, we are talking just on the iceberg. That's the overuse of the healthcare services. And there is a lot of underuse of high-value care we should acknowledge, and that's underused, and we should improve the access to that underuse. And that's more important in the LMIC setting. And just to beautifully described in this quotation from the Lancet Right Care series, that both the overuse and the underuse of healthcare services side by side in most of the countries, between countries, and within institution, and even for the single person, for the single condition. So it's both the overuse and the underuse of the condition are right there. So unaware, most of that evidence in the Lancet Right Care series coming from the high-income countries, and unaware of any systematic looking and exploration of the evidence around this issue in low-middle-income countries, we conducted a series of scoping review looking at the overdiagnosis and overuse of diagnostic and screening tests, overuse of medications, and overuse of surgical procedures in low-middle-income countries. And we followed the international guidance for systematic scoping reviews, searching for 4 databases, including context region-specific databases, citation analysis, selection of studies, and also synthesize this evidence in pre-specified 4 themes: focus, the extent of the problem, the drivers and factors related to the problem, the consequence from this, the problem of overdiagnosis, overuse of healthcare services, and any potential solution addressing this problem evaluated in LMIC settings. And we found widespread evidence. We found around 150 studies that have been conducted specifically about the issue of overdiagnosis, overuse of testing, 367 studies around the issue of overuse of medications, and about 185 studies around the issue of overuse of surgical procedures. And as you can see here, the map of the world, the gray, the geographical distribution of these studies around the countries. So the gray area, those kind of the study that, the gray area, the country that's high-income countries, so no studies expected there. And the white one is the no studies that have been published addressing this issue from LMIC settings. And the darker the blue, the higher the number of studies from these countries. So as you can see, for example, China and Brazil having a huge amount of study coming from there. And about 2/3 of this study coming from middle-income, upper middle-income countries, and with less than 15% coming from low-income countries. And around an equal distribution of the study around the WHO regional countries with a little bit higher representation from East Asia and the Pacific. I will present a few selected studies that's looking at different condition, different income group, countries, and also for different representation of the themes and the focus. So the first study about the overdiagnosis, and the classical example of the overdiagnosis, thyroid cancer. And this study, an international analysis of population-based cancer registries of more than 500,000 people, adult population, in 5 continents. And here we can see that, sorry, that's too small, but as you can see here is the incidence, the age-adjusted incidence of thyroid cancer in low-middle-income countries. The left panel is for men, and this is for women, the right one. And the red is the mortality. And what papers show the classic signal of overdiagnosis, increase in the incidence of thyroid cancer in these LMIC settings, while the mortality is constant over the years. And look at the huge variation between the countries in the incidence of the thyroid cancer, similar to the pattern that we are seeing across the high-income countries in the upper panel. So the same variation between the countries as in the high-income countries and the low-middle-income countries. So there's a huge variation in the, between the countries. There's some lag. Yeah. And another study looking specifically about the thyroid cancer in China, looking specifically about the rate of overdiagnosis in China across different regions in China. And this population also based registry study, a huge variation between the region, ranging from 85% the rate of overdiagnosis of thyroid cancer in one of the region, Shanghai, up to 50% of rate of overdiagnosis of thyroid cancer in Xinjiang. So huge variation in the overdiagnosis, even within the same country. So again, variation within the same countries. Looking at the overuse of testing, this is a study in Iran in 3 teaching hospitals looking at the inappropriate use of brain MRI, and in 3 teaching hospitals, what they found about 1/5 of these MRI scan inappropriate, overuse, unnecessary, and the cost of these the cost of these unnecessary tests in the 3 teaching hospitals around $100,000. Just to put that in the context, that's the healthcare spending in Iran. The annual healthcare spending per capita is about $900. So you could calculate how many annual per capita spending have been lost unnecessarily just in these 3 teaching hospitals in this upper middle income country. Huge impact on the individual and the healthcare system. Another example for MRI for low back pain, which we know that a lot of that unnecessary happen. Also in Iran, in these 4 radiographic centers, about 50% no appropriate indication for that MRI scan for low back pain. And another issue that's double the use, so double the amount of those people MRI scan in the private health insurance. Another inequalities within the same country, within the same, these 4 teaching hospitals, 4 radiographic center, another huge impact on the individual and the healthcare system. Looking at the overuse of medication, the proton pump inhibitor in Lebanon, and this cross-sectional study of 1,000 participants in Lebanon about the appropriateness of the PPIs in the community, about 2/3 of those PPIs unnecessary, no indication for the use of proton pump inhibitor, which is a common medication for gastric reflux disease. And they have estimated, they generalized that for the whole Lebanon, it's estimated that about $25 million wasted in this unnecessary PPI use. That's a huge number, especially for Lebanon that have just recently announced that they have financial crisis. Huge loss, financial loss for the country and the healthcare system. A reminder that about $1,300 is the per capita spending, healthcare spending annually. So huge loss of that money, unnecessary. Another interesting study looking at the potential inappropriate use of medication, a qualitative study in Burkina Faso, looking what the drivers, interview with the clinician and patients, what the driver for that potentially inappropriate medication in the elderly population, and we found similar to the high-income countries, the communication, patient-clinical communication as the driver, also the limited knowledge and skills of clinician, as well as the incentive from the pharma industry. And that's a great quotation that summed that up, though there is a surge of medical representatives across the hospitals. Huge financial incentive. Another huge overuse of antibiotic overuse. That's a huge topic, unnecessary antibiotic overuse, contributing to the overall overuse of unnecessary antibiotic. And this is looking systematic review, looking at what's the potential solution for that. Similar to the high-income countries, action plan, education campaign, the audit and feedback also have a role. Another great study looking at surgical overuse, especially the cesarean section. This is in the PMG, looking at across the cesarean section rate in 72 LMIC countries. And what they found a huge variation in the cesarean section, ranging from 0.6% in the South Sudan to about 59% in the Dominican Republic. And what's more important is the variation according to the socio-economical class. So here in the far left, is the poorest fifth, according to the socio-economic class, and here the richest fifth. Huge variation, about six-time-fold, the rate of cesarean section ranging from about 4% to about 18.4%. And what the attribution is that a mixed combination between underuse when it's needed, so when it's an emergency, there's a need for cesarean section, the poor people couldn't afford, and they couldn't have access to the cesarean section, coupled with overuse of unnecessary, no medical indication for cesarean section in the same country, in the same condition, in the same institution. So huge impact on the inequality within the institution for the same condition. And finally, about the malaria, and this is a huge problem in the low middle income countries, especially a combination between underuse of effective diagnostic solution, rapid diagnostic for malaria, to accurately diagnose malaria with the overuse of anti-malaria drug for presumptive diagnosis, just for symptoms suggestive of malaria. And this randomized trial showing that the appropriate access to that underused rapid diagnostic statistic can reduce the overuse of anti-malaria drugs by 60%. And there's no increase in the other alternative medication like antibiotics. So there is no signs of increase of unnecessary antibiotic use. So this kind of potential solution to kind of solve both the issue, the underuse and the overuse, by the same kind of strategy. So that's within condition variation and unnecessary overuse with the underuse of high-value care. So again, whether that quotation apply to the LMIC? Yes, it's apply. We have seen that variation of our overuse, underuse between countries, within condition, within institution for the same condition. But I would add that's with a great impact on the inequalities, as we have seen in the same section. There's a great impact. This overuse of overdiagnosis deepen the inequalities within the same condition and within the same country, and also with a huge impact on the individual. There's a report in the WHO estimating that about more than 500 million people around the globe will be pushed into poverty, or more than extreme poverty, just because of the out-of-pocket expenses in a LMIC setting. So a huge impact on individual impact. And finally, a huge impact also on the healthcare system. Especially the healthcare system in the LMIC setting is fragile, fragmented, with weak public health and public and primary healthcare system, with a loss of vertical healthcare system for immunization or for HIV. So without that infrastructure healthcare system, it's a real crisis. So this applies with a huge impact on individual, on the community, and also on the healthcare system. So what we need to act now. We need to act now to address this problem in the LMIC setting, looking at the universal health coverage. And that's, this is a report from the WHO and the World Bank and OECD looking at, without getting rid of this unnecessary overuse of healthcare services, it's difficult to achieve the universal health coverage by 2030, where all the UN member countries have agreed to achieve the universal health coverage. It's difficult to achieve that sustainable development goal. And if not because of the individual and for the health system, it's for the environment. And also, LMIC is a contributor to the carbon emission. And this PMG article suggesting some of the initiatives to decarbonize the healthcare system, and one of the initiatives to reduce the overuse of healthcare services, unnecessary healthcare that contribute to carbon emissions. So we have to act now, and we have to do a collaboration with between different stakeholders, patients and the public, policymaker, clinician, researcher, between countries, across countries, between the high-income country and low-middle-income country, bearing in mind that we have to think globally, but also looking at the priorities and the need for local context. So something worked for Tanzania, for example, doesn't work for Norway or Sweden. So we have to think globally, but act locally at the local level. And we're trying to address that by building a network of people that would like to work on this issue, advance this agenda. And we have a workshop on Saturday at 4:15. So you are welcome, all welcome. I would like to end my talk with thanking all the team that have worked on all those scoping review and the network, those all from all around the world working on this issue. Thank you so much. Thanks for having me.
Thank you. That was wonderful. So as mentioned, we're going to have all three speakers talk, and then we'll bring them up a little later. I asked you to think about your questions, write them down, put them in your head, put them in the app chat, and then we'll have a good discussion afterwards. So now I'm going to have to figure out how to technically get to the next round of slides. Okay, click out of there. Okay, so now I need to get Dr. LaCutla, that out, and Dr. Lagares.
Okay, yeah.
All right, great, good. Okay, for our next speaker, Professor France Lagares will be speaking about why is the ethical approach of shared decision-making suited for tackling inequality. Professor Lagares is a family physician in emergency medicine and has had some very interesting work in for primary care providers from knowledge brokers to health brokers, and she'll be providing some thoughts on her work in that. So thank you.
Thank you very much. It's very good to see people after 3 years of not traveling and not going to any conferences. So thank you for, having me here, and a special thanks to Eddie Lang. Very glad to see you again. So now you hear my French accent. So I'm from the east coast of Canada, and French is my first. Okay, it's holding on. And I may need some of my notes to keep on track on what I would like to share with you. I think I'm going to bring you to another area of reflection, and I hope it will be enriching your reflection about the topic that are the themes of these conferences. First, my conflict of interest, as it was said, I'm a primary care doctor. I've been actually practicing for 32 years in an underserved area in Quebec City. And I get research grants from mostly governmental funding agency. I won't name them here, but I'm also a holder of a Canada Research Share, so I want to thank this program for paying my salary. Briefly, my outline is to cover a little bit about shared decision-making. It's been said by our colleague, Dr. Godley, that this is maybe a strategy to address overuse or overdiagnosis. It has also been mentioned by Ray Monahan and others as a strategy to tackle overdiagnosis. But then I will bring you into an ethical landscape. Because thinking more and more about it, I thought that this would maybe help me, and I hope you, to get into another direction for addressing all those complex societal issues that Dr. Godley has shown us. Briefly, shared decision-making. It's an interdependent, interpersonal process, and I very much emphasize the process. It's about clinicians expanded much beyond doctors, so nurses, healthcare workers, and patients, exploded, important others, who work together to identify the decision point, very important. Sometimes it's something we bypass and we just go straight to the option. So first, what is the crossroad, the decision point? So people are helped in making a choice that will be informed by best evidence, but also what matters most to them. Here are some of the data from the Cochrane Review of Patient Decision Aid, also known as shared decision-making tools, led first by Annette O'Connor, now by Dawn Stacy, and she's currently actually updating it. What's quite interesting about this is that, and that's what we've been saying for a number of years, and thanks to the Dartmouth group, because there was many summers that we met in Dartmouth for the summer on informed patient. It is actually helping for underuse, that would be maybe underuse for new medication for diabetes, and also helping for overuse, so something such as the PSA cancer screening. So it seems to have an action which is about trying to get the optimal rate, which is in itself is interesting. Next evidence about, is its impact on health inequities or inequalities. Very sorry about this. Okay, so this is actually a systematic review by Marianne Durand, who works closely with Glenn Elwyn, who actually did a systematic review trying to look at studies that had assessed the impact of shared decision-making intervention, but looking at what was the impact on inequities. And actually what the signal was is that disadvantaged groups may actually benefit more than those who are not disadvantaged after a shared decision-making intervention, which again is of interest. So where does this lead me and us? I found it intriguing. I first met with Annette O'Connor in 1995, and this is why I did my degree with her from 2000 to 2005. But now reflecting back, I thought, that's interesting. Why is this that something has an impact on overuse, underuse, but also on inequities? So I would like to propose that the ethical mechanisms underlying shared decision-making may actually explain this. And as an American activist said, maybe that's a good time to put philosophy to work, as ethics is about some philosophical aspect. So here, this is actually a diagram produced by a philosopher in Europe. His name is Marc Uniandi, where he tried to actually highlights that there is not one ethic or an ethic. It's not about one ethic or an ethic. The ethic is made out of multiple lenses. But there's inherent tension in those lenses. And sometimes it helps to try to understand, because ethics is about having a sense of what you're doing is good or bad. So I won't go through all of them, but I will actually focus on those that seems to be related to shared decision making. Broadly, at the very top, there is two very broad ethical lenses. One is about being goal-oriented. I won't say the word, it's too complicated for me. And the other one is about you must do it. It's not about any goals or consequences. So already there's a tension. You either, or at the same time, do something because you're thinking about the consequences, and that's going to drive what's good or bad to do, or you're going to be doing something because it's the thing to be done. Let's go in more details. If we look at the big family of the goal-oriented ethical lenses, there's three big ethical smaller lenses: consequentialism, values, and virtue. Consequentialism. It's really about having in your head what the consequences are going to be. So what's going to drive you to do something and saying it's good or bad as the ends in mind. And it also has to do with some type of measurement, because it has to do with the happiness of the collective, of the everyone in the collectivity. So I've been in the area, because it's not a business for me, of patient decision aids, and this is an exemplar here. So last year, we were asked by the Ministry of Health and Social Care of the province of Quebec to actually design a patient decision aid for their lung cancer screening program. We did it through the Quebec Sport Support Unit, for those of you who know the patient-oriented research environment in Canada. And we got with a very large group of stakeholders, as my colleagues were saying, so lung specialists, actually from McGill, I know Roland is here, patient, primary care docs, nurses, the Ministry of Health, etc. And we devised this decision aid. You can download it, it's free. It's on a website run by the government of the province of Quebec. And I just want to show to you that this is purely consequentialism, because you look at options and you weigh the option on the fact that you have numbers of who's going to benefit, how many will benefit from it. You don't know who, and how many won't benefit from it. And we make sure that we would actually, it's here the consequences, and talk about overdiagnosis, okay? So this, when you actually approach shared decision making or engaging patient in making decision in this way of doing things, you're in the consequentialism aspect of the ethical approach. The next, values and virtues. Both are understood as interventionist ethics, because it's about working on something important. So the values would have to do with the collective good. What are the values? Liberté, fraternité, égalité. This is in France. And the virtue would be, it's the model from antiquity of being a virtuous person. So you work on yourself to get to be virtuous. What you do by the action of what you're doing is to get you virtuous. Where does this lead us in the shared decision-making or patient engagement in the decision-making? Here. There's a young woman, she's based in Aberdeen. Her name is Elena Gauthier Mamaril, and she actually defended her doctoral thesis in philosophy last year in Aberdeen, where she actually argued that autonomy and patient being engaged in the decision-making is a virtue. So that would mean that by actually working on yourself to be more and more engaged in decision-making about your health, you would get to be more virtuous, okay? And this is not very different than Aristotle, who actually said a few years ago that autonomy and being virtuous had to do with being able to make wise decisions. So very interesting work. And for those who have a very great interest in philosophy, she also embedded Spinoza into this because of emotion and reason. And why I'm showing you the Cochrane review that we led and that will inform you on how you can implement shared decision-making in clinical practice is because being virtuous is something you learn and you work on yourself. And often when you work with people from the most vulnerable part of the population, often people will come to you and say, France, they cannot do this. It's too complicated, low literacy. They'll spit out all the barriers. But the fact is that it's learnable. You can learn about it. I find it to be actually in the idea of getting more virtuous. Let's go now to the deontological must-do lens of ethics. And there's three big ones that I'd like to address. But I'll start with the duty and the right. The duty is an action that you need to actually take because of itself. It has nothing to do, notwithstanding the consequences. And one of the key authors, apparently, is Kant, where actually you don't think about the consequences. You do it because it's the right thing to do, and it is universalist, and it always keep in mind that the human being is never only a mean in itself, in himself or herself, but an end. So it's the must-do, and it's your inside moral law actually derived from reason. The right is actually what you must do, notwithstanding the consequences, but now an authority is telling you that this is the right thing to do. So let's have a look. Here, for example, charters of rights of patients would be in the lenses of the rights. The Australian one, I hope it's updated, and the Canadian one would indicate that you need to bring patient into the decision making because it's the right thing to do. There's a little delay when we push, sorry. Okay, now proceduralism. That's my coup de cœur. It means heart blow. This one is quite interesting, actually, because, and I need to look at my notes. It's an ethical approach according to which moral justice is constructed and discovered by means of a procedure. The ethic is based on the idea that the definition of right cannot be given a priori, nor can it be discovered in a tradition, nor can it be defined by an authority, nor can it be made manifest by simply analyzing the nature or essence of the good. So you bring the arguments at the table with peoples, and you actually process it. And I may have gone just a little bit faster. So an exemplar of it, to some extent, is an approach by Habermas, where he lay out what's the essential of communicating in a proceduralist approach: inclusive, equal participation, no constraint. And think about it, because often patients with their clinical teams, there are constraints because they're afraid to actually not being seen as the good patient. It's been shown in some studies, so they will actually restrain. And honesty and transparency. I have put in the upper corner what I had said about shared decision-making, and I see a very strong resemblance. So I find that this ethical approach of proceduralism is quite interesting from the perspective of inequality. Because as we get to be more aware and more sensitive to inequality and equity, and as its knowledge base is building, it's not only building in the healthcare sector, but here I'm just citing Thomas Piketty, an economist français, who actually leads a world inequality database. And that's a book he published last year. It's just been transferred in English in April this year, where actually reminds us that inequality is above all dynamic, a social, historical, and political construct, so you need to talk about it and co-construct your understanding of it. And this is even more important because this is a survey when we're talking about new inequality, new types of inequality, like you were talking about the LMIC. Because in fact, what we understand is maybe healthcare is producing a lot of carbon emission, but they're not the one having the most in the world, but they're the one who suffer the most, okay? So here in Canada, we did a survey of about 1,000 or so, or 1,500 Canadians, asking them about if they were engaged in making decisions with their providers. And well, no surprise, it's very low. But there were inequalities because older people, people from Quebec, people from immigrant background, etc., actually experience less and less of being engaged in the decision making. So obviously, that's a new kind of inequalities and inequities. And in summary, because I want to respect my time, as I was reflecting with this type of lenses, I thought that the ethics of shared decision making, so that's what I had tell you, that I would bring you somewhere else, reconciles both teleological, goal-oriented, and must-do ethics. Because often you have one way of doing stuff, and maybe that's the tension that we feel sometimes even like a clinician, I must do this, versus, well, let's look at the consequences. So it has that capacity to reconcile those diverse lenses. It draws upon a rainbows of ethical lenses, and it opens a dialogue that is so necessary to help co-construct a consensus about justice and equity. So my argument was that this may well be the mechanisms by which it actually is favorably impacting on both underuse, overuse, and inequities. For those interested in the field of shared decision making, our colleagues in Denmark are hosting the annual conferences, or annual conferences next week in Denmark. And the ZEFQ journal in Germany, I think we have colleagues from Germany here, has a whole issue on shared decision making across the world. So every country who wanted to do it, or researchers in country, actually produced their paper and update on the status of shared decision making. And with colleagues from Canada, we did publish the one on the status of shared decision making in Canada. Thank you to you. Thank you so much for being here. And thank you to my colleagues in Quebec, to the team's member, even the patient I meet on a regular basis, because everything here has been derived from my work as a clinician and also as a researcher in shared decision making. Thank you very much.
Thank you, that was wonderful. I'm sure it's generating a lot of thoughts and ideas for some questions and discussions afterwards. So let me get out of that. Get out of that. Great. And for our final speaker, Nav Prasad is an associate professor in family and community medicine in Toronto. His research has been in the area of equity, fairness, especially related to access of care. And he's today going to be talking about nourishing equity, starve overdiagnosis machine. Thank you. And he's got a little buddy who's going to help present too. Boys, that could be great.
All right, great. Thank you so much to the organizing committee for inviting me here to speak, and thank you all for welcoming my son Tagore, who's going to be co-presenting in support with me here today. I am really grateful for support for my research, mostly from the government of Canada and the government of Ontario. I'm a family physician in Ontario as well, and that's how I derive part of my salary. It'll become clear very soon why my work is not supported by for-profit entities like the pharmaceutical companies. The machine that I want to talk about today is not this a robot created by military engineers that literally could eat people up. The machine that I want to talk about instead is the pharmaceutical industry and other for-profit companies that underlie a lot of decisions that end up being made for our patients. It's an $11 trillion industry based on some estimates of the revenues. It's more profitable than many other sectors. In this audience at a Preventing Overdiagnosis conference, you would already know that current guidance in bone mineral density screening would indicate that unselected populations of older adults should really routinely be going to get their bone mineral density checked. And that is true despite the case that we know that many fractures occur in individuals who are not identified as high risk through this sort of process, and that when you're stratifying risk for a fragility fracture, the bone mineral density is of questionable value beyond other clear risk factors that have been identified. What you might not know if you haven't paid $3,000 for this market research is that bone mineral density testing is represented as a growth industry, and there are talks about how large the industry could grow within the coming 5 years. And the decisions are, the estimates are in the billions. So I think when we're talking about what ends up happening when a patient speaks to a doctor or a nurse practitioner about whether to have a test like this, we have to understand that there's a really powerful force operating underneath the surface. And what I'll also try to suggest today is that overdiagnosis and overuse of interventions of questionable value is intimately linked with inequities. And in fact, they're both underlaid by this very powerful machine, these behemoths, these for-profit entities that would prefer to continue feeding individuals through processes that have already been established rather than taking a truly patient-centered approach and thinking about what are the basics that people need. And I think as we're thinking about what to do in the best interest of our patients, we have to balance a tendency to want to counter messages that are supported by or directly coming from the pharmaceutical industry and other for-profit entities, these behemoths underlying care, with an objective to ensure that people who are experiencing disadvantage, and in our societies today, this would include women, transgendered individuals, racialized people, low-income individuals who experience disadvantages. We have to ensure that they are getting proven interventions. The pandemic represents, in my view, a potential opportunity. Because there was more attention than there usually was to inequities during the pandemic, several of my colleagues and I in Toronto came together during the pandemic to make some recommendations about how to promote health equity when it comes to health outcomes. And we made 13 recommendations. Most of them are related to policy changes like equitable access to a basic income that would allow people to purchase healthy food and live in safe and healthy housing. But we also made several recommendations related to preventive care, including ensuring that individuals at high risk are screened for hepatitis C and HIV. Building on this work, we're now developing additional recommendations in the area of preventive care. And here, I just want to point out through some of our preliminary work done in partnership with Dr. Aisha Lofters at the University of Toronto, we've surveyed some of the literature and identified some conditions where there are both inequities in disease-specific mortality and in preventive care and access to preventive care services. And they're listed at the top of the slide. And just want to mention by comparison that we haven't, based on our review of the literature, identified similar disparities when it comes to other conditions or risk factors that are currently the subject of positive recommendations for preventive care, such as bone mineral density testing. So I want to provide some preliminary reflections on this ongoing work. I think one area where we might be able to promote equities and address overdiagnosis at the same time is by improving access to primary care in general, making sure that people who are not connected to a primary care provider now become connected. I also want to mention somewhat more controversially the issue of routine visits or preventative health visits. So I think there's a mixed literature here. There are some studies indicating that there's little benefit in terms of all-cause mortality. Some other studies indicating a benefit in terms of mortality in certain populations, such as older adults. What I would like to suggest among patient populations experiencing disadvantages, where we know their rates of preventive screening are lower, could it make sense to prioritize those individuals for these preventive care visits, where, for example, discussions around shared decision-making could take place. For cervical cancer screening, rather than organizing this service around the way that we provide care, where we expect patients to attend our clinic, usually during working hours when it would be difficult, for example, for a factory worker to ever come into the clinic for a preventive care visit. We should also, I think, be thinking about other ways to administer those services, such as HPV self-testing. But I think there are some important cautions, with all of these proposals, and I'll mention a few. First of all, for cervical cancer screening, there are some questions about the accuracy of self-testing, just like there's, I think, some questions right now about the accuracy of self-testing for COVID. So that's one issue. I think the other issue is we don't want to get carried away with a technological solution being the answer to inequities, because the issues are more systemic, and I think it's quite likely that inequities are going to be reproduced using newer technology. So I think we want to take a systemic approach and make sure that we are always thinking about the basics in addition to these fancy technologies. The other cautionary note that I want to offer is that just reducing utilization is not going to promote equity by itself. So I don't think it's true, and certainly it hasn't been proven that cleaning up bone mineral density testing, if we were to reduce or rationalize bone mineral density testing, it's not clear to me that the resources we save there, let's say in terms of the clinician time or the healthcare dollars wasted on irrational bone mineral density testing, will actually be used to ensure that proven interventions are received by people experiencing disadvantages. So there's a leap of faith there, actually, assuming that will happen. So that's something that we need to study and understand. And I think when we're talking about addressing inequities, it's unlikely that that will happen by accident or as a matter of course. I think that we have to center on inequities and invest resources in addressing them from the ground up if we expect to see real change. And what I hope that we don't see is a raising of the bar for evidentiary standards when it comes to deploying preventive care services to people who are experiencing disadvantages. And while I think obviously it's important to ensure that we're administering services that have been proven, I think at a certain point we have to accept that there are studies linking, observational studies in most cases, linking access to primary care to better health outcomes at the population level, and we need to do our work to advance equitable access to care. I want to end off just by saying a few words about the guidance that's out there right now, as I close by indicating an area where we need to place more attention. So we did an audit or survey of clinical practice guidelines in the United Kingdom, the United States, Canada, and Australia. And we identified very few clinical practice guidelines that made recommendations that were aimed at addressing inequities. At the same time, the main emphasis of that audit was determining who is involved in creating this guidance, who is on the panels in these documents that provide guidance to clinical care around the world. And we found that racialized people, especially racialized women, were routinely excluded from the clinical practice guidelines panels. And just on my last slide here, I wanted to end off by saying that we really want to focus on getting proven services to people experiencing disadvantages. Thank you very much.
Thank you. I'm going to ask all the speakers to come on up front. We'll kind of arrange some chairs. They'll have a microphone. We'll have one microphone that they can pass, and then we'll ask audience members to raise their hands, and then we'll pass around microphones to them. I know I've got a couple of thoughts, but since there's a hand up already, why don't we go there? And then Jim's going to let me know if there's things online. And feel free to ask an individual or to have it go back and forth between individuals.
I would like to address the issue of the graphic that was shown as a shared decision-making tool in Quebec. That was a grand experiment in the United States. The first time a law was passed that said you had to do shared decision-making, you had to do a decision aid. That specific decision aid that you showed comes from an article by Peter Bach and Michael Gould in 2011. And the idea behind shared decision making is to give good, clear information to the patient so they can make the right decision. And the problem is that that decision aid is almost completely inaccurate. It grossly underestimates the benefits of screening and grossly overestimates the. So it's a real risk if you're going to mandate shared decision making to make sure that the information that's given is accurate.
It would help me. Is this a comment you'd like me to comment on, or is there a question? Sorry, English is not my first language. Because do you want me to comment your comment?
I would like to comment on the ethics of providing inaccurate information in shared decision making.
Okay, I understand. Okay, I think. Okay, so I've been in this area since 1995, and there was no difference in doing this actually decision aid, if I might say so. Is the part that is the most difficult about actually producing a decision aid, that's what I've experienced, I don't know others here, is actually what you're actually saying, is the data. I totally agree with you that it's, even when I was preparing, I was going around with some colleagues, and some of them, actually from Choosing Wisely, Samuel Boudreau, said the numbers are not right. But while producing the decision aid, we did what is called patient engagement. So we had patients around the table, we had lung specialists, we had the Ministry of Health, we had many different stakeholders. And the most difficult part was the data. Totally agree with you. What we decided to do at some point was actually, it was a service given to a client. The client was the Ministry of Health and Social Services, was to actually try, with our help, to find his way of which estimate would be put into the document. So now that I've said this, every one of the decision aid, because I'm not a producer, I help doing them, but I don't call myself a producer, it's always about the data. But let me bring you to something else that we never pay attention. Is a patient decision aid based on the IPDAS, International Patient Decision Aid Standard, does not only contain data and information. I agree it's very important, but people actually underestimate all the other pieces of the decision aid, where actually they are engaging in a discussion, and that actually also, that's been documented, will reflect on what matters most to them. So I'm not having a satisfying answer to you, but that actually brings me back to the proceduralist to some extent, because when you design a decision aid with so many different stakeholders around the table, obviously at some point something is going to take it somewhere. And in fact, before we did this decision aid, we did an international scan of decision aids of this topic. And most of them had different data, even. But we believe, I don't like to say I believe, but we face a pluralist world where multiple voices are around, and we have a sense that the data that's been included is probably, we hope, not completely off the cliff, and that in fact also the decision aid will actually open the discussion, the communication, the exchange around the issue. And to reassure you, if this is a bit of a reassurance, we're due to update it right now, because the deal was only 1 year. Usually a decision aid is good 2 years, and we said, okay, it's so messy, we'll do only 1 year. So we're going to re-embark with a whole process of relooking at the evidence. But thank you for your reflection. Thank you so very much.
Thank you. I want to kind of play off that a little bit and get responses maybe from everybody about how these types of informational tools, whether they're informed or shared decision makings, can be framed and targeted to try and reduce these inequities and disparities, because it's difficult to have a one-size-fits-all type of tool. And so what kind of work do you do that may get beyond biologic constructs of disease, if one believes that that's true, to get into some of the social determinants of health, values, preferences, access to care, things like that in these tools that can be rapidly and efficiently and effectively be done in care systems? Maybe start.
Sure, thanks for the question. I would just say the tools, hopefully we would all agree, the piece of paper or the 1,000-person diagrams, those would be part of a bigger system. And I think, obviously I'll be biased here as a family doctor, thinking that, part of the process, an important part of the process, is a relationship based on trust between a patient and a healthcare provider. And that would be, I would suggest, more important than any piece of paper or any diagram. So I would, my main reaction would be that we have to ensure that all of the things that should surround that diagram are in place. And so that would include people actually having access to a provider that they trust, and having, even more generally than that, trust in a system. So a feeling that the system, a healthcare system, is there to help them, and they're not, just sort of feed for a bigger machine that that might be directed at or created for other people. So I think you're more likely actually to trust in the accuracy and the helpfulness of such a tool if some of those wider issues are addressed.
And others, and sort of along the lines of that, have you found in any of your work that words and framing and perceptions matter between different groups that may be for equity, marginalization, things like that?
Is the question, sorry?
It's really, yeah, but you just keep moving the microphone down.
Okay.
So I will answer maybe about the tools.
Yeah.
I think because that's also important. So I think the guideline that developed in the high-income countries get their way to the low-income countries, low-middle-income countries, and we have to be careful as there is a process and framework to adapt these guidelines to the each individual country, in the low-middle-income country. I think we need kind of framework to adapt and adopt these kind of decision tool to the low-middle-income countries, because even the data is the same. The healthcare system, the limitation in the healthcare system is different, the context is different, and that should be built in that framework or the process how we can translate the decision tools from a high-income Canada to, for example, a low-middle-income country. So I think we need that process to adapt these tools because it's difficult to just use the same tool as it is.
So if you're interested in the special issue, there is a paper from a group of researchers from Western Africa, Central Africa, actually giving the voice to Africa about what is the state of decision making, how they perceive it, and actually what you're saying is how it's going to be, how it will need to be contextualized. So maybe that could be, you know, an interesting read.
So we have a question submitted online. Jim, you want to read it? One second, we're going to take the one that was submitted online first. Thank you. Well, we got time. We'll get to folks.
I think this is for Lai, where the questioner is asking if the WHO guidance is mitigating the effects of inappropriate use. In your research, do you have any ideas about that?
Yeah, I think there's a lot of WHO guidance, and it's difficult to have a just generalized word to say all the WHO either mitigate or increase the problem. And it's difficult also to generalize that across all the groups, income countries, because as we have seen, there's variation across the countries. So the low-income country is not the same to the upper middle, even within that LMIC setting. So it's difficult. But I think some of them could mitigate, but the other could widen the problem. And some of the things that WHO maybe should play differently, the vertical system, healthcare system, so like kind of support for the immunization vaccination without the infrastructure, the primary healthcare, improving the primary healthcare infrastructure, or for example now for the COVID vaccination or the COVID healthcare intervention, HIV interventions, those kind of vertical system deepen or weaken the infrastructure, the primary healthcare, preventive healthcare sector.
Yeah, thank you. Bonjour, France. I think this question is mostly for you, France, but happy to hear from the other panelists. Right. We did not make this a plan. No, this is not
planned. It wasn't planned. We haven't seen each other for 2 years.
But here's the situation. As a practicing family doctor, I still see people getting cancer screening tests ordered without any shared decision making going on, you know, just sort of as a checkbox exercise. And then I was listening to your, you know, very interesting discussion of ethics and philosophy and trying to relate that to the reality that I'm seeing on the ground. And so as I listen to you, I get the feeling that it's unethical for doctors to be ordering these kinds of tests when the patient is not properly informed. And that was sort of my kind of conclusion. I wanted to get your take on that. Do you think it's unethical, and whether it would help to frame this kind of test ordering behavior as unethical in terms of getting to better decision making?
So as you're going to answer that, I'd like you to kind of frame it also in, if so, how do you operationalize it? Because as I think is commented on, you can have a tick box, or you can have something that can get you past that metric that won't get you a bad ding, but you want to do it well and efficiently.
It's not the worst I've seen, Roland, okay, the screening for cancer. A personal story, because that was the topic of my PhD. In 2000, about, any pregnant woman, at least in the province of Quebec, so there's about 80,000 of them every year, would get into an office of any physician, be it OBGYN or a GP, and would have a piece of paper, go to the lab, and have actually screening for trisomy, okay? They had no clue it was being screened, okay? And that actually had some bad situation. Now we're at the very opposite right now. When you go to the system in Quebec, you need to actually read a piece of paper and sign it. I think you do obstetrics, so you know about this. Where I'm getting with this is, I'm not going to answer to you about is this ethical or not, because, but for sure, we've been going from a non-engagement in making decision, because to be engaged in a decision, you need to see a decision point, okay? And at least that's what some of the tools, because I agree it's only a tool, it's not the process, will help people actually consider. So for the screening of cancer, there would be multiple reason with all the lenses to maybe provide you with a support of what you think now. But it would be presumptuous of me to give my own answer on this for now. Thank you.
Another question, just what we get the microphone. Do you have a mic? Got it, all right.
I got it, yeah.
Do it.
Thomas from Germany, thank you for the interesting talks. Two things I would like to mention. One is the decision aids mostly are an aid, because people who are very sure about what to do to go for screening then are confronted with benefits and harms, and they realize the real uncertainty of such a decision. So in fact, they mostly end up quite confused, because so it creates the opposite of what it said. Still, I'm a fan. I think we need that. Of course we do, because that's reality. The thing I wanted to say is, the second thing is that most people don't know about benefits and harms. There were 2 systematic reviews in JAMA Internal Medicine some years ago, which showed that both don't know, and if you ask them to give a best guess, then they overestimate benefits and underestimate harms. If you have, so a strong driver of overdiagnosis or any too much medicine is defensive medicines, because physicians are afraid of being sued for not doing something. If you have a law that requires physicians to use decision aids, and then they do something. We have that, for example, in Germany, in the single guideline, which is on coronary heart disease, that before you get a catheter, you must use a decision aid which belongs to the guideline, and you have to document it. So, do you know of any cases where patients who had a complication during such a procedure afterwards sue their physicians, not having seen that decision aid, because they would have decided differently if they would have? And what happens then? So we could turn a mechanism that is driving overdiagnosis or too much medicine into its opposite by using that. I think having this in as a law, or at least in the guidelines, that you should do that, might be a major force to prevent overdiagnosis by informing patients about the real uncertainty which is in every decision, by informing them about benefits and harms.
So from an ethical lens, you would be in deontological and rights. Okay, it would be outside authority from yourself. But I would like to turn to Stephen, because the reason being that I think in the US, Michael Barry, and others have written about cases of litigation around decision aid in the case of cancer screening for prostate cancer, okay? So I wouldn't be the best person to tell you about cases from a law perspective. However, there is a systematic review of the impact of decision aids. And it shows, but again, it's a systematic review. It has a lot of limitation, that it reduces the discomfort with the decision, decisional conflict, and decisional regret. And there is sometimes and again, it's population data, so you will always have the specific case that is not taken by the mean, but it does reduce decisional regret. But I wouldn't go into the law because I haven't had a situation, and I would refer you to Michael Barry, who has written extensively about this. There was a case in the US.
I'll just quickly add, I think before we take a law and order approach, I think we just want to think about all of the implications of that, and including, if we're looking at it from an equity lens, who is likely to end up on the receiving end of the complaints, if we take a law and order approach. It's not going to be, I don't think, equally applied, just like other laws are not, and so we want to think about that. The other thing is, if you agree with my proposal that really there are systemic issues involved, I would suggest that we first take a law and order approach, for example, to the way the pharmaceutical industry interacts with the medical profession and the health sector in general. And that hasn't been done. There's some really prominent ways it hasn't been done, like in the opioid crisis, killing thousands of people each year. That hasn't been done yet. So it would be odd, I think, to apply it at this level.
Thank you. Stephen?
Yeah, I don't really know how much to add about the legal cases, so I'm not sure what to say, but I just would say that in developing decision aids, it's just so critical, and this gets back to one of the first comments, to assess their impact, and that's really not easy to do. So one part of it is comprehension, right? But there's all kinds of judgment that goes into all these things. How you say things, what you include, what you don't include, the way you present the data. These things really need to be studied carefully. And I mean, someone once said the public should no more be exposed to an untested message than to an untested drug. So I think the bar for testing these things should be really, really high. And I know people in this room have done a lot of work with decision aids and some really outstanding work, but there are a lot of bad, poorly tested decision aids out there. So I don't know the answer about the law, but in terms of as people who are producing these things, I think it's the burden of responsibility is on us to make sure that we develop these things carefully and test them in a way in the intended audience to make sure that we're not having unintended consequences.
Yeah, let me play on that one just a little bit. My experience, I'm a former U.S. Preventive Services Task Force member, but that many of the recommendations now have come out as not whether to screen or don't screen, but they end up saying, we recommend shared decision making, which really gets at Stephen's point, which is, have they really tested what they're recommending on the outcome that's part of their analytic framework? I think we all in this room would agree that talking with our patients, informing them, getting their preferences and values, doing that efficiently and effectively. But does it rise to the level of a recommendation statement, and how should guideline groups do that to ensure good access and equity? Thoughts?
Can I just add in comments that comes from the people outside here, where someone has said, I think actually the mortality benefits presented in the tool is overestimated, not underestimated. I think personally that means there's still a lot of debate about actually the numbers that go into these tools, and the point that Nav was making, the numbers that go into them, and how we should subdivide. I mean, for breast cancer, we've got them for 3 age groups. You know, how many subgroups should we have different sets of data for to help make sure we're targeting, giving the right information to this particular person? And that gets really complicated, and both in how you interpret the original data and then how you actually try and match the person in front of you to which tool.
Again, my take of it now is that producing the data or doing the data synthesis is a political action. It's a political action. Because again, we are in a pluralist world. And if you're actually interested, because at least from where I stand right now, we are very much into co-design, patient engagement, the multiple voices, everybody, like we had this beautiful slide from Nav where you see who's on the panels, okay? Here in Canada, equity, diversity, inclusion is a non-negotiable, okay? So where I'm taking you to is that when you produce those tools, if you only focus on the numbers, and I have nothing against number, believe me, you're maybe missing the boat. Because one of the things people need to maybe realize is at least now we're talking about decision point and options, okay? That may seems like a small steps, but when I started 32 years ago as a GP, there was no decision point. And in 2000, for pregnant women, at least in our province, for screening for trisomy or Down syndrome, there was no decision point. So maybe I'm getting older and I hope a little bit wiser health, there's a wiser healthcare. But there are small steps that we have attained and achieved, even though they seem ridiculous because they seem, oh, that's so obvious. But it wasn't obvious at the time. And again, the numbers are important, but if you just focus on what numbers is the right one, we may be actually missing the boat that Dr. Godley showed us. There's a much bigger boat out there, sinking actually. So that's, again, I think why I thought that I would go back into looking at some of the ethics aspect of this to try to get my head around, because you need to be in a relationship. Nav, I've said it, everybody has said it, you need to be in a relationship. You co-design, patient engagement, the multiple voices, people who are not included need to be included, and suddenly you will see something that you haven't seen before.
Thank you. Do you have a microphone?
Yes, I have. I'm Jean Dubovetsky. I come from France, so please forget my accent. 2 points. The first needs no comment. I'm getting older, and I have still never seen a white middle-aged audience of health professionals listening to women and young black men. So thank you for that. Second, I don't like very much the idea of shared decision-making. And this is why. I think the only people that should make decisions are the people concerned with their own health. So, well, we come from a world where doctors made decisions for people with an idea of paternalism and maybe consequentialism. I can't say them. Consequentialism. Okay? And it's a step forward, but it's not the last step. I think we're only half the way.
Thank you. Maybe some of the others had a comment, but then we're going to get to the questions, but that individual back there in the white sweater top, I think, has been having her hand up for a while, so I'd like her to, and then we'll come. Yeah, please.
Thank you. Oh, can you hear me?
Yeah, go ahead.
Thank you for that last speaker, actually. You know, it made sense to me, and what I was trying to say or wanting to say was that I think, Franz, what you're talking about is when we're talking about the big picture, I think the big picture is that we open that conversation with people, that we at least start talking to them and encourage them to ask those questions, whereas before, perhaps it was a little bit of a paternalistic view. I mean, I look at my parents and I look at my grandparents. Doctor knows best. Don't question, just do. But now things have changed, and I think we're recognizing that, you know, that conversation is important. Another comment that is related to the pandemic is that, you know, shared decision making maybe one time is not going to be enough anymore. We know that to catch up to all the surgeries we've missed, to all the visits that was missed, that it's going to take us at least 2 years or more, up to 5 years. So what you're having a conversation about today, that shared decision making, I mean, it doesn't matter what tool you use, the conversation you're having today, are you going to have to revisit that? And what needs to change in the system in the post-pandemic period about shared decision making to address the changing individual who has had to wait so long for their procedure, et cetera, so that it's a repeated conversation, not just a one time. And I know we'd been talking about shared decision making a lot, but I also wanted to just quickly say about pharmaceutical companies. And I'm recognizing, I worked in primary care for several years, and I hear you about the influence that they could have on physician prescribing behavior, et cetera. But now I think they've even gained more power. They're actually, they're advertising themselves as being able to have a social impact. And so they're also targeting health administrators in the name of, and whether maybe there is, I mean, in the business world, they will create partnerships and provide funds to do social good. So I'd like to, know what you think about that aspect.
Thank you.
Sorry,
Briefly, because I'd like to try and get 2 other questions, and if we could keep our questions and comments brief and succinct. Now,
Sure. So I totally agree that the pharmaceutical industry gained in power during the pandemic, mostly through the rollout of vaccines. And that was a good, I think, demonstration of how the industry promotes inequities when we think about vaccine inequities globally. And in terms of preventive care and shared decision-making during the pandemic recovery period or after the direct threats of COVID-19 abate, I think we really need to prioritize disadvantaged patients, our patient populations who have been disadvantaged during the pandemic and prior for access to preventive services.
thank you. Question over there. Oops.
Sorry about that. One of my residents said to me recently, about a year ago, with the tool for PSAs in Canada, which I use every day, and I think it's really helpful, but he's from Nigeria, and he said to me, but Dr. Johnson, surely black men are at higher risk and this doesn't really apply to them. So I'm just wondering whether we can have our decision tools adapted to be able to meet those more high-risk groups. And then the other thing that's I feel probably missing from those tools, the 49-year-old lady that I had that had a mammogram in November and then the following July showed up with a mass and a rash and an invasive cancer. So it's not just the mist that screening has. It's not a perfect tool. I think people think, well, I've had my mammogram, everything was okay, so therefore I've got nothing to worry about. Thankfully, she did present with her symptoms, and that's something I heard. Sorry, I forget the name of the American breast surgeon that's talking this week, but I heard her talking in 2015.
Dr.
Laura, yeah. I heard her talking in 2015 and basically saying, women should get to know their breasts, and I've said that to patients ever since. So anyway, thoughts on that?
Thank you. I'm going to get one more question, then I'm going to, then Franz, and then that Loy's been kind of a little quiet, so I'm going to get him to get the last word.
My question is for Loy.
Oh, good.
Yeah.
I double down.
I was just wondering, after all that body of evidence that you have gathered with your large research on over-testing, over-diagnosis, and over-treatment, what are the next steps in your research? Is your team going to influence the governments to regulate, or the medical schools to educate, or run a public campaign, or start an international collaboration?
Thanks. I think the next step will be to understand more the problem in the local areas, local countries, but also to advance the agenda, the research, and for the intervention, implementation research, looking at the solutions that have been shown to be successful in other countries and try to implement that, working with the people and the groups in the research team and others to advance the agenda, especially the implementation, evaluation, research for intervention that can reduce the overuse, and also reduce the overuse at the same time, improve the access to the underuse of healthcare services.
So thoughts about equity, we got just a couple minutes. Equity in terms of new technologies, and particularly access to cares that might relate to virtual visits. I mean, that's been proposed as one way to markedly increase access, but in other ways it may increase disparities because of the ability for many individuals to have access to virtual technology. Thoughts like that and how to address that? Anybody?
Yeah, I would say in my own practice, I definitely didn't see virtual care helping to address inequities during the pandemic, and it wasn't like my most disadvantaged patients were more likely to access care virtually when that was the prime option. So I would just repeat what I said during the presentation, which is that we shouldn't get too distracted by these technologies and assume that they're going to address systemic issues that have been around for a long time. So I think there certainly is a role, but we would need to understand better who's going to benefit from their rollout.
What I've seen during the pandemics with the most vulnerable people, especially the older adults who were locked down in their housing arrangement, was to actually have any reason to go see a doctor, so they could come and see a doctor because they could see someone in real. So even if they had virtual care, and I would suspect some of them had because they came from, residential housing arrangement which cost a lot. I mean, they wanted to see someone. So it was very interesting because we would look at the list and it was about very minimal complaints, and by the end of the encounter with this person, we felt that this was his only or her only way to see someone. That's my experience.
Thank you. Well, I want to thank the speakers for staying efficient and on time, and for the audience members for having great questions. I think it was a rich engagement.